Yeah, hi guys, thanks for your patience while we were setting up. My name is Frisch. I am one of the fourth year residents, one of the chiefs. We're going to be talking today about hot debriefing, and I want to thank our SIM faculty for joining me for this presentation. Essentially, the first 10 minutes is just a quick presentation. Hopefully you guys all did the pre-reading, and then we're going to demonstrate from some samples of debriefing and ask you guys for feedback. So my objectives for this talk, debriefing is important. I think people may not be immediately obvious all of the ways that debriefing is important, but it can improve teamwork and communication. It's been shown in multiple studies to improve patient outcomes. And obviously for us, we're all learners here, and everybody is really a learner, lifelong learning. And so it can improve learning for your whole team. Our ED is pushing for more debriefing, and we agree because it can help address systems issues. When you identify systems issues in debriefing, that can later be brought up with administration and actually make changes to help address issues that you find. And we're going to talk about hot debriefing today, which is the type of debriefing that happens immediately following the clinical event. And that's the type that we're going to choose because this is immediately within your clinical experience. Like, let's say you're in CCT or you're at downstate and you have code, you can follow up one of your cases with one of these samples of hot debriefing. And all of your team's already present. There's less risk of bias, and it creates the potential to address these types of systems issues, or at least elicit them when it's all fresh in your mind. I put up my objectives for the slides here. And mostly I just want you guys to leave the session with a little bit more experience and comfort with debriefing, and being a little bit more comfortable in leading debriefings yourself. So there was a pre-survey. Thank you to some of the people who filled it out. If you haven't, I'm going to be sending you guys an email and reminding you to fill that. So this is what I created from your pre-survey on what you guys think are the biggest barriers to debriefing within our hospital systems. The first one that's documented is always time. And then the second two are gathering and comfort. So I thought I would break these down for you guys and give you a little bit of workarounds and suggestions for ways that we can work around these to improve our debriefing frequency. In terms of the barrier of time, this is often cited as the largest barrier to debriefing, and in our institution survey, it was no different. ER doctors are getting interrupted like every 30 seconds, so it can be hard to prioritize debriefing in the clinical environment, but you can use some techniques to try to work around this. Number one, limit the time of your debriefing to 10 minutes. If you guys are finding that your debriefings are running longer than 10 minutes for your hot debriefings, try to work on ways that you can improve that. Make the debriefings more concise. Use a structured approach such as the Pearls format that was in your pre-reading and that we're going to review in just a moment. And also, if you find discussion on things that are perseverating on issues that you cannot solve within the group that you have with you for the debrief, don't stay on that topic. Instead, just table this discussion for later. Bring it up with administrators or with whoever might have the power to help you think of a solution at a later time. And lastly, if people are concerned about time, you can always say at the beginning of your debriefing that if anybody needs to leave because of patient care or whatever may come up, everybody is free to step away at any time. Okay, the next barrier that I want to break down is gathering. This is, I'm sure you guys have all experienced this, where you try to get a group together, a group of people, even let's say we have a notification for trauma, and you can't even get everybody who should be in the room into the room. So I can totally understand this, and it can be difficult to find space for this gathering as well. Some tips that I have for you to this effect are pick a time and stick to it. Just say, we're going to debrief in 5 minutes or in 10 minutes, and this is where it's going to be. Whoever can come will come. And once people start to see that you are debriefing, more people will come. And if they can't come because they're working on patient tasks, then whoever is able to be there, it's going to be helpful for them. It's going to be helpful for you guys. So I would suggest just do it with whoever you are able to gather at a time that works for most people. For a place for debriefing, these are pictures from 2 of our facilities. Do you guys recognize the room on the left? What?
Like the telemedicine room.
Oh, yeah. It's the telemedicine room. Yeah, room 11 at UHB. So I think that's a pretty reasonably big room that you can probably have some privacy and comfort for debriefing. And another option would be like room 11, or sorry, room 9, the GYN room is another option. Or if there's nobody in the trauma bay, like the resuscitation bay at downstate, you can use that. In KCH, I have up here a picture of room 3 in CCT. oftentimes they leave room 3 open for pediatrics, so it might be the most likely to be empty, or we can use the family room, or if there's nobody in the trauma bay, you can use the trauma bay for the session. And lastly, comfort. So I'm not talking to you Zoom folks about the kind of comfort that you're all having on the couch. We're talking about comfort in terms of leading and debriefing. I know that a lot of residents may not feel like this is my place to be leading and debriefing, especially our junior residents, but I want to pose to you guys that in our survey and just in surveys in general that have gone on to see who's doing these hot debriefings, it's mostly attendings and then mostly senior residents and nurses as well. At other institutions, nurses more commonly lead these debriefings, but our institution, I personally haven't seen it happen, although a few of our nurses are trained in debriefing. So basically, you are going to be growing into this role where you are expected to be the one who is the debriefer. Start to think about now improving your practice for comfort in debriefing. There's no better time to practice than when you're surrounded by people who may be able to help you with this. And you can talk about debriefing with your team, after your debriefing. How did I do? Did I lead it appropriately? Did everybody get the messages after you're done? Kind of have a discussion like that. In order to be more comfortable with debriefing, because I know it's easy to say, but it may be difficult to actually implement, we have given you guys all the PEARLS method. You guys all have pocket cards, yes? So if you guys are at home, this is in your pre-reading, and I have all of these cards for everybody. Whenever you see me, I will pass them out to you. And they're also posted in the CCT outside of the trauma bay and in pediatrics in Kings County. And we're working on getting them posted at UHB as well. So you can bring your pocket card with you. You can reference the PEARLS posters that are in the clinical areas and ask your team to practice with you when you have cases that you would like to debrief. Okay, and last but not least is the concept of psychological safety. So making sure everybody feels comfortable with the debriefing. Everybody meaning the entire team. So effective debriefings require some degree of psychological safety. It's really important because you want the perception that it's safe to take risks and express your thoughts without getting penalized, without being embarrassed, and without feeling like you'll be punished if you don't know the answer to some questions. So basically start your debriefing off with some sort of statement of psychological safety to set the tone. So this could be the statement, on your PEARLS card right here, there's actually a statement that's listed in the sample phrases. It says, our goal is to improve how we work together and how we care for patients, and everyone here is intelligent and wants to improve. So you just start with this basic assumption that we are all here for good reasons and we're all smart and capable. Okay, I'm gonna briefly review the PEARLS guide for debriefing. I do want you guys to be familiar with this guide because this is, I think, a really simple one, and also it's the one that we're using as an institution. It's posted in the clinical areas. So what I want you guys to do is, if you have these cards with you, just take out your cards, and if you're at home, you can reference your pre-reading material to look at the PEARLS. So I want to focus for a moment on the analysis phase. We talked already about the psychological safety part. That's the first part, setting the scene, where you just introduce the debriefing topic and make sure everybody is in a safe space. The second part is reactions. You just ask how everybody's feeling and gather reactions, initial emotions. And the third part is a description, or ask somebody to summarize the medical details of the case. The fourth part, the analysis part, I think is the most difficult to lead or to feel like comfortable with leading or asking these questions. So I want to break it down. You can on the back of your card is a breakdown for the analysis section. So you can take a look at all of these performance domains, for example, decision-making, leadership, teamwork, and you can ask your team specific questions so that you can elicit how did people think that these went during your case. And there's a few different ways that you can use to do this. So the first one is called the learner self-assessment. It's probably the easiest. It's where you ask people what went well and what didn't go well, or what you think that you could improve. You might have heard about this called plus delta. And the second option is called focused facilitation or advocacy inquiry. This is where you say an I saw or I heard statement so that you can ask a question afterward. So for example, I saw that you were having trouble putting the IV. What do you think was going on there? How do you think you can better troubleshoot this for the future? The third option is directed feedback. So this is an I saw or I heard statement followed by next time, maybe you want to consider X, Y, or Z. So give a suggestion for next time. And then finally, once we're done with the analysis phase of the debriefing, you move on to the application or summary phase, which is where you really summarize any learning points. You summarize anything that any systems issues that were brought up that you want to address later, or anything really that needs to be followed up. If there's a performance gap, let's say somebody doesn't know the answer to a question during the debriefing, maybe this is a good time to say, okay, Chrissy, can you look this up and get back to the team about it? So I'm just going to point out very briefly, Health Scholars is our simulation website where we are going to be distributing more information about simulations for the entire department. But this is also where we're going to be recording our debriefings. The forums are a little bit in flux, but I hope that with the pre-reading material, you guys are all able to log on and locate this forum. We'll give you a little bit more information once the forums are updated, but this is the way that we're going to bring up the systems issues that you find with our administration. And the administrators, I'm not sure if they've already logged in or if they are going to, but they will have access to your form so they can see your feedback. And this does not get placed in the patient record. Okay, so moving on to the meat of the presentation. This is where our sim faculty are really going to help us out. So we are going to run through a practice case, and after we show you guys the case, we're going to demonstrate 3 different debriefings. Each debriefing that we demonstrate, what I need from you guys is to pay close attention to the debriefings. There is a debriefing assessment that I gave you all in the pre-reading called the DASH, or Debriefing Assessment for Simulation in Healthcare. This is just a guideline of what you should be looking for when you are evaluating the debriefings. But you know, I think that a lot of the stuff is probably going to be intuitive. So if you didn't read it beforehand, read it afterwards so that you guys can have a good idea about ways in which we can evaluate the debriefings. For these cases, we're going to do 3 debriefings, and I'm going to ask you guys after the debriefing examples if you can help us figure out what the pitfall was for each case. Every case has a specific pitfall that I'm hoping you guys will be able to recognize. And so let me introduce the players to you. So we're going to switch over our camera. We have Dr. Carolina Camacho, who's playing the attending, and Dr. Jessica Stetz, who is playing our fabulous nurse. Dr. Sneha Tapki, who is playing the senior resident, Dr. Pamela Gennaro, who is playing the PGY2 CCT junior, and Dr. Jane Kim, who is playing the MS4. So we all know. Okay. Let me just fix my sound.
Great picture. You have a lighter. Or maybe something. Yeah, she's just reading these so that. All right, so yeah. So you guys can hopefully see on 2 different views the front of our screen, and so I'm just going to run you guys through the case while our players act it out. So we have a trauma notification to CCT. EMS brings in a 25-year-old male who's stabbed in the chest and back in multiple places. The patient is tachycardic and tachypnic when he arrives, but he is speaking, he's talking, he's anxious, he's speaking 3 to 5-word sentences, tachypnic, and has a blood pressure of 80/50. His vital signs otherwise he has a heart rate of 120, respirations of 35, and he's saturating 100% on 2 liters nasal cannula initially. So our junior in CCT, Dr. Gennaro, steps out to ask the clerk to call a level 1 trauma, and the clerk says that the trauma calls back and they can't make it for 10 minutes. They're stuck in the operating room, and the X-ray is also with them, and they're going to be late as well. So Dr. Taki, the senior resident, assumes the airway position, and Dr. Gennaro, the junior resident, is on exams and procedures. Dr. Kim, the medical student, is helping out nurse Sets with IV access and with placing the patient on a monitor. And Dr. Camacho, the attending, is running the code from the foot of the bed. So she starts to call out for ABCs, and Dr. Taki says, patient speaking, airway is intact. Dr. Gennaro listens and says that the lung sounds are diminished on the left side. So Dr. Camacho tells Gennaro to prep for a left-sided chest tube, and meanwhile, the patient is on the monitor. The saturation starts dropping from 100 to 85% on the 2 liters. Dr. Gennaro gowns for this procedure in record timing. She's been in sim lab. She does the chest tube perfectly. And meanwhile, Dr. Sets is placing IVs, and our MS4, Jane Kim, does not realize. So Dr. Sets is placing IVs with Jane Kim. Neither of them realize that Dr. Gennaro has been putting in this chest tube or has actually completed the chest tube insertion. There's no pleurovac that's set up, and somebody in the room shouts, "Can anybody get me a pleurovac?" and looks at our medical student, Jane Kim, who says she does not know where they are or how to set them up. So Dr. Taki is at the airway still because we're thinking that this patient's saturations are continuing to drop and wondering if the patient needs intubation. Dr. Sets, well, nurse Sets in this case, finds and sets up a pleurovac, and Dr. Gennaro releases the Kelly-Klein from the chest tube, but there's no bubbling and there's no draining pneumothorax. Dr. Taki, our senior resident, re-listens to the lungs from the head of the bed and notices that the left lung sounds are actually okay, but the right lung sounds are diminished. So she grabs the ultrasound and verifies the pneumothorax on the right side. The patient remains with an oxygen saturation of 80% and with good mental status, so she leaves her position at the airway to place a right-sided chest tube, which as she's inserting, Dr. Camacho, who's overseeing the procedure, realizes that she's leaving the last port of the chest tube outside of the chest and corrects this, and she inserts the chest tube, and the patient's vital signs stabilize, and the trauma arrives, and the patient is brought over to the CAT scan. So, while that's in progress, we move on to debrief. I'm just going to review some facts of the case for you guys to refresh your memory, because I know that it may be difficult to hear the case verbally. The facts of the case are, we had a patient that came in with a right-sided pneumothorax, and we had Dr. Gennaro, our junior, accidentally call out that there was a left-sided pneumothorax and placed a left-sided chest tube for this patient. X-ray was not down, trauma was not down, we had no verification of the pneumothorax. And then Dr. Taki realized the mistake was she would listen to lung sounds and place the right-sided chest tube, although her technique was not perfect. Dr. Stats, nurse Stats in this case got her IV access, and Jane Kim, who was asked to get the pleurovac, did not know where it was and did not know how to set it up. So, moving into our initial debrief, this one is going to be led by Sam.
Okay, that went crazy. I don't feel like I can trust you guys. What happened out there? I messed up.
Yeah, I was not following everything that was going on. I missed that the chest was facing the wrong side. I didn't verify what's going on. I feel like guilty about it.
Oh my god, I feel like I can't trust you guys if I'm in a code or like in a recess with you guys. That went not so good.
Is that how IV sounds? No, definitely not.
No, it doesn't usually go like that.
Oh,
That was bad.
I was putting in an IV. You didn't even tell me you were putting a chest tube in.
You're supposed to be watching, right?
I was putting in an IV. I would have gotten Florida.
We gotta fix this situation. What are we gonna do?
It was all my fault, when she said there was no breath sounds, I didn't confirm with her. And then all the miscommunication happens that she plays it just one side.
I'm usually, my physical exam is usually on the right side. I got confused because I was on the left side, and I should have, I don't know, I just missed it.
Okay, we're gonna end this scene and move on to you guys. How do you guys feel in the audience and on Zoom that the discussion went?
The best.
Yeah, so thank you for sharing. We are hearing that it's not very psychologically safe, so there was no statement of psychological safety at the beginning. Anybody else have any feedback? So I think, the tone of this debrief was off, and that's a good point that you mentioned. We didn't start with a statement of psychological safety. We didn't start by asking for a case summary, so we might not have all been on the same page. I would say that this, see if I can get my thing. Yes. I would summarize the problems with this debrief as lack of structure. So they didn't really use a formula. Dr. Taki just said, like, you know, this went horribly, like, what's wrong with us kind of thing, and everybody felt really bad. And the way that we can work around this is by having a structure and knowing it well and using it every time. Yeah, it's funny. The first pearl for this debrief is to use your pearls format. So you know the format, reference the posters, reference your pocket cards, practice it, become familiar with it and comfortable with it, so that when you are leading these debriefs, they don't end up unstructured like this and leaving a sour taste for all of the participants. Okay, we're gonna move on to a second debrief. This time, Dr. Gennaro is gonna lead the debrief. I'm just gonna ask you guys to speak a little bit louder, because I think they're having some trouble hearing. Yes, so we're gonna move on, and Dr. Gennaro is having a mic.
So let's take a few minutes to talk about what just happened. I just want to preface this by saying our basic assumption is that we're all intelligent, capable people, and we all want to do our best. And essentially whatever happens here stays here, and we're here to identify certain systemic issues that we can present to our administration to improve our processes. So let's just start by, how is everyone feeling?
I feel flustered.
I feel guilty.
I wasn't really on my game either. Sorry about that.
So confused.
Just so we're all on the same point here, can someone just quickly summarize our case?
So we had a guy that came in who was a trauma, stab wound, wasn't standing very well. It sounds like he was able to talk, but someone said that there were no breath sounds on the left side. It sounds like we put the chest tube in the wrong side and the patient wasn't getting better. So we reevaluated the patient and found that he had a pneumothorax on the right side. So we put a chest tube in. There were some issues with IVs and putting in the chest tube properly. But we saved the patient, he went to CT.
So what went well in this case?
I think we did the right intervention for the diagnoses, except it was on the wrong side.
And then when we figured out, we quickly and did the right thing for the patient after, and tried to get everyone on board with the same thing.
So going off of that, what could have gone better? What exactly would we have done?
Placing the chest within the right side.
Yeah, I know, I suck. I'm sorry. Okay.
I think there could have been a better communication or rechecking of what was going on. If someone could confirm the breath sounds, or we have the tool of ultrasound, so we could ultrasound to confirm that there's a pneumothorax, since we don't have like X-ray right in hand.
There was no pleural sec also. They're looking for it, I don't know where it was. I don't understand what happened.
So I guess we can prepare ahead of time that we have all the equipment we need for any interventions we are going to do.
I should have asked. I'm sorry. I wish I had communicated that I wasn't sure when you were doing that.
I feel like we all should have, I guess, just known better and
And
done
then-
better.
And then the other group also was placed in there, not in a good way though, so there was still a hole outside. I don't know why also that happened. But
But I noticed that you saw that I did that and you corrected me, so thank you.
I mean, you're a senior resident, you should know better.
exactly.
I'm still in my learning phase, so it was a learning experience for me. I will never do it again. I've learned my lesson.
Okay, we're gonna end scene there. So, anybody have any feedback in terms of what you think that the pitfall of this simulated debriefing was?
So it seems like it's more structured this time around, but I felt like it fell flat, especially the application summary phase, maybe a little bit analysis phase as well. It was initially good, and then they sort of towards the end.
Okay, yeah, so we're hearing that the structure was there, but maybe it wasn't flushed out in terms of the summary and analysis phase. Anyone else?
It was. That's the same.
Anyone on the Zoom?
Yeah, Noah said something.
What are we seeing?
All right, Noah saying, people became defensive and seemed to want to place blame rather than education.
Yeah, that's a really good point. So Noah said people seemed defensive and wanted to place blame rather than education. So I think you guys perfectly picked out what we wanted to illustrate, which was not closing performance gaps. Basically, in this debrief, we had multiple performance gaps that were brought up, like the chest tube being inserted on the wrong side and no verification of that. We talked for a second about ultrasound, but it wasn't really that well thought out or that well discussed how we can prevent that in the future. Similarly, we mentioned that Jane Kim, our medical student, didn't know where the pleurovac is or how to set it up. We didn't really address that at all. And we also didn't really address how we were going to better communicate with our nurses in terms of telling them, okay, we're placing the chest tube now, we need the pleurovac. All of these things were brought up, but they weren't really settled. So that, I think that the structure of this debrief was definitely improved and used the pearls format, but like you said, wasn't totally complete with the analysis phase or with closing the performance gaps. So what can we do to prevent this? In summary, when a learner brings up something that they're unfamiliar with, try to get them to a place where they understand it. And if it doesn't happen in the debrief, it can happen after the debrief. You don't need to know, just because you're the person leading the debrief, in this case, it was our junior resident, Dr. Gennaro, if she doesn't have the tools to answer all of these questions, that's totally fine. Somebody else in the group can answer the questions, or if you can come back at a later time and email out an article or, get back to your team with the answers to these questions if there's something that needs addressing. This is important because it's how we all grow, how we all improve, and if we're going to use debriefings for our learning, we should at least address what deficiencies are brought up. Okay, we're going to move on. There's a third case. This is the last case. So we're going to do one additional debrief, and this one is going to be led by Dr. Camacho. And then after the debrief, we'll do a similar thing and a small wrap-up.
Okay, guys, so we're gonna spend 6 minutes debriefing about our last case together. We're gonna do this for just learning purposes, also give some feedback and improve patient care. What we're talking here is gonna be keep in between us. The only thing that maybe is gonna be showed to the administration is the things that we can improve in system-based manners. First, I wanna say that I believe that everyone in here is capable, is smart. I want to do the best for the patient, okay? And I want to ask everyone to be respectful with each other. How are you guys feeling right now?
I'm pissed off.
Okay.
I'm flustered.
You guys have anything to share with us?
I feel really bad. I didn't do a good job. Sorry.
Okay.
Just don't know how to do anything, so nervous.
Someone want to summarize the case for us?
Yeah, we had this 20-something-year-old stab wound.
The multiple part of his body. He was hypoxic, tachycardic, tachypneic, and then no breath comes on one side of his chest, and we placed the chest tube in the wrong side. And then after that, we placed the chest tube in the right side after some clarification on what was going on in there. Okay? Anything else to add in the case? Okay. All right. What things went well in this case?
The patient is okay, I guess.
Okay. What other things went well?
I think we were timely and fast, even when we did something wrong, we fixed it.
Okay. Well, we fixed it. We can do better. Well, we fixed it. Anything else?
Nurse Specs helped me find the pleurovac. Now I know how to set it up.
Thank you for that. Okay, so if we have this case again, what we can do to be better in the next case?
I'll not put the chest tube on the wrong side.
Yeah, that's a good idea.
I'm gonna have the pleurovac ready in advance.
Okay.
I'm gonna practice my procedures so I know how to do it without needing to be told.
Yeah,
But it's either one.
I agree with you. Anything else that you guys want to add? Any other concerns or issues? So learning points, we should verify on which side we're gonna place the chest tube because that actually can make damage to the patient. So please, let's work on that.
Okay, and see. So what did you guys think about this debrief?
Much better.
Much better. Anybody think of anything that could have been done better with the debrief? There was really just one small flaw with this debrief.
It seems like Macho interrupted during the Bills against talking, so that right there.
Okay, I swear I did not plan to share with all of you. But he said that Camacho took over with all of the talking and interrupted and didn't let everybody finish answering. So
was crushing.
yeah, I know that was hard for you. Yeah. So essentially, there were some interruptions. There were some times when people's feelings were shared but not validated, or just not like what they said didn't seem like was appreciated by the facilitator. And so this critical flaw is what I call facilitator overtake. In this case, it was the Carolina show. This is what happens when the facilitator takes over the entire debrief, doesn't allow others to answer questions or start to talk over other people. You should try to be cognizant if you might be prone to this type of overtake. Especially, I think as you become more comfortable, you may have more ideas or more things that you want to share, and you want to make sure that it's a space for everybody to share how they're feeling or what their thoughts are for the case. It's for everybody. It's not just for the facilitator, and it's not just for the facilitator to instruct others. It's for everybody to gather the emotions and also gather the performance issues or systems issues, and then for them to be addressed collectively as a team. So while there is somebody facilitating, they're there to facilitate and not overtake. Some ways that you could possibly address this if you think that you might be prone to being this type of person is wait 5 seconds after asking a question so that other people can have a chance to answer. Sometimes people ask a question and then just go ahead and start talking again. So try to wait a full 5 seconds. And also if somebody is sharing something, especially if it's emotional or something maybe a deficit in their knowledge, acknowledge it. And if you have a suggestion or if you have a question about it, you can try to elicit why did this person not understand this, or why did this procedure not go correctly. You can ask them as a follow-up, but make sure that they are feeling acknowledged and not just okay to everything that they said. Okay, so I'm gonna just can I turn my mic? Okay. Okay, so we're just gonna wrap up, and in summary for this whole activity, I really just created this session because I wanted to improve our residents' comfort and also knowledge of how to do debriefings and how to do them effectively. I think that we're not, from what I've seen at least, I'm definitely guilty of this. We're not necessarily doing debriefings as often as maybe we should be. Like if we have significant cases, we have patient deaths, we have trauma codes, stroke codes, those kinds of things could all be followed by a debrief. And I know that our clinical environment is really busy, but it is really, I just wanted to highlight, it is very important that we take 5 or 10 minutes for debriefs and try to acknowledge some of the barriers and how we can get around them in terms of thinking about time, space, and gathering, and how we can make these actually happen in a clinical environment. So in summary, you guys all have your pearls outlined. You should use it so that you have an effective format for your debriefing. If you stick to the format, you'll be more concise. You'll be able to do these in a shorter manner. And if it doesn't take more than 5 or 10 minutes and it's worthwhile, then it's going to be catching on that people think that these are effective, and also that we're able to do them in the clinical scenario, in the clinical setting. And in terms of actually doing the debriefing and pitfalls, try to remember the 3 that we went over today. And every time you're seeing a debrief, you can ask yourself, how was this debrief done? Did I like the style? Did I not? Do I want to be a facilitator like this? Or is there some part that you can pick out that you can maybe address? So the ones that we talked about are lack of structure, and to combat this, using the Pearls guideline for your format.
If there's another one that you really love and you're familiar with, that's okay, but I would say try to stick to one format, and since our institution is adopting for us, consider using that one for yours. If somebody starts to mention that there is a performance gap or a knowledge gap and there's questions, acknowledge them, and if you don't know the answer, that's fine, just get back to them at a later time, so close all of your performance gaps. And lastly, facilitate the debrief, don't overtake it, so allow time for people to answer questions and allow time for acknowledgement of the reactions from your participants. And so with that, I will ask if anybody has any comments or questions.
Did you guys have any recommendations for when, I mean, I think the mood kind of right after is a little off, like a way to transition everybody to become more comfortable and less nervous, even though like just saying like this is an open, safe area. Is there anything else you guys like have to recommend creating a safe vibe in space?
Do you mean like between interdisciplinary teams where people are
Like the
afraid of judgment? Or?
Yeah, like the nurses with a junior resident, a senior resident, and sometimes the junior may feel hesitant to ask something because they think it's dumb.
Mm-hmm.
And even though you preface it, do you guys have any other tips for that?
Maybe saying something like, if you're not comfortable sharing something right now, like you're available to talk about it.
Privately, yeah, it's a good idea.
Later.
Also, when you are gonna debrief, you have to be sure that you're in a good place. You should never start a debrief if you're gonna leave the debrief and you don't feel that you're there and you're not gonna be hearing that and you're gonna address everything, and maybe you're still angry or something happened, you need your time also. You should never start a debrief if you are emotionally,
Not there.
developed in the case. You need maybe a little bit of time, then you can guide the debrief and take care of everyone and have safety.
I think people naturally debrief after a difficult case. I think like you see nurses kind of gather off to the side as they're charting, talking about the case. You'll see the docs on the CCT bench already talking about the case. So naturally, we're debriefing. We're just not capturing that moment as an interprofessional group. And I think that's what we want to change. So just say, hey, that was really tough. Let's all come together and just talk about that. And just hear each other, because that was really tough for me. And I think if you give, your vulnerability, and I know Seth does this so well, that was really tough for me. Like you give everyone else permission, I think that's so helpful,
I would also add, if I could say, that when you start your debrief, starting with a psychological statement of safety, but then also you can specifically address if you feel like the teamwork or the communication was off. I would say specifically address it. Say, I felt like it was a little bit difficult to organize as a team, or that the roles weren't unclear, or whatever you might have been perceiving. How do you think that we can address this, or what did you guys feel?
Especially if you have just a little bit of time, you can also mention your objective for that debriefing. Like, we can talk today, we're gonna talk about communication in the debrief, and then if there's other things you can talk later on with the residents or something, because you only have just a limited amount of time, and you're not gonna be able to cover everything that you want.
And the more you do, like the more debriefs you do, the techs will see, the nurses will see, and they'll feel more comfortable doing them or participating in them down the road. That's something I've found.
I think that's a great point to really draw in all members of the team. So bring in the clerks, bring in all of the nurses, everybody who was there, especially after really studying cases. I can really remember sitting in specific rooms and talking about cases where we were all really upset. And it was actually very bonding. I think it's very therapeutic. It allows you to go on with it.
But also another thing I want people to remember is to have some couple of takeaway points, because we're really good at venting and it's very therapeutic. But to walk away and be like, this is what I think, these are the 2 points I got from it, 2 things I'm gonna change. Kind of walking away with that is always solid and good. And also if you feel like your attending has a debrief with you, feel free to reach out to your attending and be like, we need to debrief what just happened. We take time for you to do that, because your attending might be busy running around, but knowing that you want to do it, they will take time out to do that. Don't be afraid to ask.
So Stacey, 2 points. First, that was an excellent exercise. I think to watch it and to go through the 3 different scenarios is fantastic. What about a busy shift? You just don't have time. So that seems to be what comes up on the surveys, not only here, even nationally, is there's just no time.
Mhm.
So now shift is over, we've already made sign outs for the new team. But it was a scenario like you had here that you really think you need a debrief, so what would be the alternatives?
So that's a different kind of debriefing. It wouldn't be necessarily hot debriefing unless it's immediately after the event. You can have like a later debriefing, which may follow similar or could be a little bit of a different format, because the events are not going to be as new or as clear, and you can have different recollection from what initially happened. Do you guys have any suggestions for that case?
I think 5 minutes at the end of the shift is still valuable. The important, and that doesn't take so long. 5 minutes, you know, now we can sign out. There's no patient safety issue. Can we sit down in this room for 5 minutes, 3 minutes, and just go through what just happened, so we can go home and let it go and learn something.
Maybe even do it at sign out if you didn't have a chance to debrief it before.
In cases like that, also you can mention, if it's a very busy day, let's say that the nurses have a lot of patients, you can give them the permission to leave the debriefing in the beginning. If you have any emergency, there's any other patient cards, say you can leave, and then we can talk apart.
Anybody else? Any comments, questions? Anybody on Zoom?
Yeah, Monisha said, CUS, I am uncomfortable, I feel unsafe, and I have a safety concern.
Oh, yes. So CUS, there's a poster. It's part, I think it's part of ISEPS.
Just part of teams.
Team Steps, yes. Not ISEPS. As part of Team Steps, there's a poster in CCT that basically talks about addressing a situation that you think is wrong and words that you can use to address them. So I'm uncomfortable, this feels unsafe, and what is the third one?
I have
I'm
safety
concerned.
concern. Yeah.
Yeah, I'm concerned.
Cool. I just want to say thank you to everybody here. They actually moved this lecture early because of how important it was, and you guys did an amazing job, so thank you guys.
Yeah, fantastic.
Yeah.
Okay, thanks, guys.